Hi, I'm Dr. Suzanne Lippert, and I'll be speaking today about altered mental status. This is part 3 of 3. So this lecture will emphasize, again, that altered mental status is multifactorial. But it will also emphasize that alcoholism has many significant complications. And we'll talk about the treatment for alcoholic ketoacidosis, which includes IV fluids, electrolyte repletion, dextrose, and thiamine. And we will again emphasize that altered mental status are dynamic and sick. So let's review our case. We have a 62-year-old alcoholic man found holding an empty bottle of alcohol, walking unsteadily. He was combative and somnolent, alternating between the two. He reported nausea and vomiting for 3 days prior to his arrival in the emergency department. He was found to be hypoglycemic to 46. He was treated with D50, became more alert, his diaphoresis resolved, and his glucose improved to 120. However, he still remained confused and had only a score of 14 out of 15 on the GCS. His heart rate remained high at 122, and his respiratory rate remained high at 20. So we did a more extensive evaluation. So when we reevaluated the patient and performed our sample history and physical exam, we found that he had evidence of chronic alcoholism, cirrhosis, and active delirium. We then thought through a very broad differential diagnosis and performed diagnostic testing and initial treatment. The testing revealed that the patient did have ketones in his urine, a CO2 of 12, and an anion gap of 23, so likely a ketoacidosis. So let's think a little bit more. There are multiple contributions to altered mental status in this patient. Initially, we thought, okay, well, he's probably intoxicated. They found him with an empty bottle of alcohol. We also found that he was hypoglycemic, and we've now found that he has ketones in his urine and an acidosis, so he most likely also has an alcoholic or fasting ketoacidosis. But we gave really considerable thought to whether or not he may have had a traumatic injury from a fall while being intoxicated and unsteady on his feet, or an assault while being very combative. We found no evidence of traumatic injury on his exam. We considered also Wernicke's encephalopathy. This patient is very high risk for that. He's a chronic alcoholic. So that still remains on our list as a possibility of another contributing factor to his confusion. Similarly, alcohol withdrawal remains on our list because this patient, again, is a known chronic alcoholic. And he's been nauseated, he's been vomiting over 3 days, and he may not have been ingesting his usual amount of alcohol. We considered toxic alcohol ingestion and sent off appropriate lab tests to evaluate that possibility, effectively ruling it out. We thought about DKA, but in the setting of hypoglycemia and no prior history of diabetes, this is very unlikely. We thought about lactic acidosis, but again, his lactate was within normal. We also thought about his liver disease causing a possible coagulopathy that then resulted in either intracranial hemorrhage or GI bleeding. He has a fairly normal neurologic exam other than his confusion. And we performed a rectal exam that revealed no blood in the GI tract. His hemoglobin and hematocrit were also within normal limits. We considered hepatic encephalopathy. And on exam, the patient had no asterixis, and on lab tests, his ammonia level was within normal. We considered SBP, spontaneous bacterial peritonitis, given the evidence of ascites that he had on exam, but the patient had no abdominal tenderness at all, and he has no systemic signs of infection. And we considered hepatorenal syndrome, given again the evidence of liver failure that the patient has on exam. But his creatinine levels were normal, and his electrolyte levels were essentially normal, other than the acidosis. We also considered severe pancreatitis, but his lipase was also normal, and again, he had no tenderness on exam and no signs of peritonitis. So we're left with intoxication, possibly now leading to alcohol withdrawal in the time period from, when he had a binge alcohol ingestion to where he is now. We've considered Wernicke's encephalopathy, and we know that he had hypoglycemia and has evidence of alcoholic ketoacidosis. So let's talk a little bit more about alcoholic ketoacidosis. Ethanol metabolism results in a redox shift, and this results in decreased gluconeogenesis and resultant hypoglycemia. So I'm not going to get into all of the biochemistry of it, but it's just important to understand that ethanol metabolism in and of itself can decrease gluconeogenesis and lead to hypoglycemia. Now, as the patient's alcohol level then is decreasing, right? So he probably hasn't had a drink now for at least several hours, if not longer. And as that alcohol level decreases, and if the patient has also effectively been fasting, so choosing alcohol over food, then we can see this increase in catecholamines and cortisol. They undergo a stress response as their body is tending towards alcohol withdrawal. This also then leads to lipolysis and fatty acid delivery to the liver. Ultimately, as those fatty acids are delivered to the liver, we see an increase in ketone production, an increase in acidosis, and sodium and potassium losses. So as the patient actually goes from an alcohol binge into early alcohol withdrawal, we actually see that all the hormonal responses to that increased physiologic stress lead to increased ketone production, acidosis, and electrolyte losses. Let's talk a little bit about the clinical manifestations and whether our patient really fits them. Alcoholic ketoacidosis, again, it often begins with a binge drinking episode and then early withdrawal. So often what you end up hearing is that these patients have become nauseated and vomited in the several days prior to their presentation. And that nausea and vomiting has actually precluded intake of the same amounts of alcohol as their body is used to. Now, this wasn't true in our patient, but commonly patients with alcoholic ketoacidosis also suffer from diffuse abdominal pain. And that, again, has kept them from drinking their normal alcohol levels. Patients are tachycardic, both from fluid losses from the nausea and vomiting, but also from early withdrawal and the catecholamine response. And tachypnic, because of the respiratory compensation for metabolic acidosis. One other thing to note is that these patients are usually more alert and lucid than patients with DKA or diabetic ketoacidosis. Now again, that wasn't true in our patient because his picture was complicated by hypoglycemia at the same time. And that's not uncommon. A small percentage of patients with alcoholic ketoacidosis will also present with hypoglycemia, as will a small percentage with hyperglycemia. So how do we treat it? What are the most important tenets of treatment of alcoholic ketoacidosis? One is fluid resuscitation. These patients are usually extremely dehydrated. The second is electrolyte repletion. As we saw in the physiology slide, the patient often has sodium and potassium losses as their acidosis increases. And three is dextrose with thiamine. 4 is to evaluate for and treat alcohol withdrawal so that you can blunt the catecholamine response that is keeping this cycle producing more and more ketones. So fluid resuscitation, we just start with a simple normal saline bolus or lactated ringers. You really need to get their hypovolemia improved. So normal saline bolus of 2 liters. Second, electrolyte repletion. So these patients are often low in potassium, magnesium, and phosphate. So most importantly, you need to check the potassium and the magnesium and begin repletion immediately. Third is dextrose. This needs to be tailored a bit more to the patient, given their initial glucose levels. But starting at D5 half normal saline, in addition to the bolus that you're concurrently giving, it's a good start. And finally, you also want to give thiamine to any malnourished patients or alcoholics. And as we stated earlier, this should not delay the administration of dextrose. So let's review our main points that we really don't want you to forget. We have to check a bedside glucose on every altered patient. We need to provide dextrose immediately. Thiamine, 100 milligrams IV for alcoholic or malnourished patients, should be given with the dextrose, but do not delay the dextrose. If it's going to take a few minutes to get the thiamine prepared, give the dextrose immediately. Now, our patient, is he stable or unstable? So let's just list out some of the characteristics of this patient. He has a persistent altered mental status. He improved from a GCS of 12 to one of 14, but he's still altered. He has stigmata of cirrhosis. He was found to have hypoglycemia to 46. He has a persistent tachycardia to a heart rate in the 120s, and that may be from fluid dehydration, the ketoacidosis, and early withdrawal. He was hypovolemic. He was found to be hypokalemic, hypomagnesemic, and he has this alcoholic ketoacidosis with an anion gap of 23. Given the persistent tachycardia, as I said before, he probably has early alcohol withdrawal at this time. So where should he be? What is the appropriate disposition for this patient? The patient should be going to the intensive care unit, at least until his tachycardia is improving, we've repleted his electrolytes appropriately, we've addressed his ketoacidosis and closed that gap somewhat. So in all, altered mental status, again, there are multiple factors that are likely contributing to each individual patient on one clinical presentation. Alcoholism has many significant complications, and we cannot simply just attribute the patient's altered mental status to intoxication without evaluating for those possible complications. Our treatment for AKA, or alcoholic ketoacidosis, is fluid rehydration, electrolyte repletion, dextrose administration, and thiamine. And altered mental status patients, they're dynamic, they're sick, and it is incredibly important to use the emergency medicine approach that with an initial evaluation, thinking, acting, and then frequent and regular reevaluations of the patient.